Okay, so hello everybody. It is a real pleasure and an honor for me to be able to be part of this wonderful initiative, which is this 24 hours marathon of live streaming of robotic surgery around the globe. And I want to thank and congratulate especially Professor Wiklund and Dr. Justin Collins for this wonderful initiative and for all the energy they have put in order to make this happen. I also want to thank here the two partners who are responsible for all the recording here in my hospital. This is Stefan and Geert, and myself. My name is Alex Mottrie. I am a urologist in the OLV hospital here in Aalst in Belgium. And I am also the president of the EAU Robotic Urology section and the president of the Society of Robotic Surgeons, SRS. So today I would like to discuss with you the future and also the new developments we can expect in robotic surgery. So Dr. Mayo already told us back in 1930 that the only thing that is permanent in surgery is change. And indeed, when we look at the last decades, the evolution has been tremendous. Here you see an image of an operating theater of about 80 years ago. And you see that the surgeon basically only needed a spoon and a fork and a knife to do open surgery. While, and this is a video clip of modern times, Charlie Chaplin, already back in 1932. And this is an eating robot. And you can see that unfortunately this robot was not so safe at that time, but I can assure you that the one we have available today is much better. But at least this video clip shows us already that mankind has already been dreaming for about a century about robotics in daily life. Actually, the robot we have available now is a Da Vinci system, and this is not really a robot, but it is a computer-steered master-slave telemanipulator which is able to perform one single task under direct control of the operator, and it allows manipulation of the instruments in the operation field. And you can see that through this telemanipulation, we can control the instruments in the abdomen of the patient, and the instruments are doing exactly the same, but only miniaturized movements. So that enables us to do much more precise surgery than we were able to do before. So why do we want robotics in urology? Well, the answer is quite simple. This device offers us the possibility of doing classical laparoscopy, but in a natural, intuitive way, without the disadvantages of classical laparoscopy, with 3D vision and with instruments movable at their tips, allowing us to do this very precise handling which I was talking you about. And this is an example of the OR as it is today in our hospital, but also in others. You hardly see the patient anymore, and the surgeon is away from the patient and is in a console where he controls the robotic instruments which are placed inside. And also for the assistants, we have now 3D vision available so that they see as good as the surgeon does in the console. When we have a look at the evolution of this minimal invasive surgery throughout the last decade or two, you see that basically in the beginning, about 20 years ago, we had the traditional laparoscopy who entered the ORs in urology. But since 1909 we had the first Da Vinci standard system available, which changed into a Da Vinci S system, which had 4 arms, while the standard system in the beginning only had 3 robotic arms. And then since 2009 we have also the Da Vinci SI available, which has not only 1 but now 2 consoles. So we can basically or work with two robotic surgeons on the 2 consoles, and also for educational purposes it is a big advantage. Here you see again an example of this old-fashioned Da Vinci standard system with 3 arms. And on this image you see this Da Vinci SI, and on the video screen you can see that you can work now with 2 robotic console surgeons. One is doing the real surgery and the second one has in the 4th robotic arm the control, and there he has this robotic suction device which helps us a lot to be able to assist in the best possible way. And of course we all know that since last year we have now the new tool, which is the Da Vinci Xi, which basically enables us to be much more, how do we say, we can now much easier have access to the 4 quadrants of the abdomen, which is especially useful where we want to do surgery, like in abdominal surgery, or when we want to do a cystectomy, where we want to have access to the 4 quadrants of the abdomen. What are today the indications for robot-assisted surgery in urology? Well, basically you can see that we can use robot-assisted surgery for all indications and all procedures. So here you see that in the morning I can make my robotic coffee, where not only we put in a sugar but also some milk, and afterwards I can also stir it robotically before to drink it. No, without joke, I believe that because of the cost efficacy of some procedures, I think that the cost-benefit analysis of this robotic coffee is not quite positive. But I believe that robotic surgery is basically useful where we want to do a very meticulous exeresis of a tumor, or where we want to do reconstructive surgery inside the abdomen without having to do a big incision. And our main indication today is a radical prostatectomy, where we do nerve sparing and where we have to do a reconstruction, where we have to do an anastomosis. And of course surgery is in constant motion. We are looking for perfection in order to reach the trifecta. And the trifecta is of course that we want to cure the patient from his cancer. We want to obtain continence, and if possible as early as possible postoperatively. And thirdly, we want to maintain the ability for potency. Thanks to robotic surgery, we have now more and more insights in microanatomy. We now know much better about anatomy, and if we know better things, we can also deal with it more easily. And we know that the anatomy of the periprostatic tissue is very complex. You see that there are not only nerves and vessels, but also some fascias, and that the nerves are very close to that the prostate. So we can really, I will not say that this is microscopic surgery, but it is very close to it, because we can choose millimeter wise how much tissue we leave on the capsule, or how much we have to stay away from it in order to be on one side oncologically safe, but on the other hand to spare, if possible, all the functions, that is the continence and the potency. There are also now much new developments in robotic surgery. I often compare robotic surgery like a smartphone, where we have more and more apps that make it available to do much more, to use much more new tools that help us to do even better surgery than we were able to do yesterday. Here you see an example of the drop-in probe that is brought inside. This is the ultrasound that we are doing intraoperatively, and through the Tile Pro we can bring it in the ultrasound image into the console vision, so that we have an exact image of the ultrasound directly in the console. And this has been a big advantage, especially in the robotic partial nephrectomies. We are now doing a test together with Imperial College from London, where we have basically this 3D images of the kidney and its tumor and its vascularization, which we can, through this iPad, bring into the Tile Pro again, so that we have not only on one side the ultrasound images, but also these 3D reconstructed images on the other side. So that allows us to see directly on site the exact vascularization. So we don't have to get out the console anymore to look at the images. And since then, we were much able to do the micro dissection of the vessels and the tumor without with having the images directly in our console. Another new tool is fluorescence imaging. You know that fluorescence imaging necessitates a new camera, which is now standard available in the XI, and through the laser is now exciting the indocyanin green, which is brought in through an intravenous injection, and this fluoresces is all what is vascularized. So basically, ICG binds to the plasma proteins in the blood after having injected it intravenously, and through this laser the ICG is excited, and with this new vision we can now see much better the vascularized tissues. And we use this now for kidney surgery, where we want to do, when we want to do a selective clamping. We can use it to see whether the clamping has been effective enough or not. And we can check the vascularization of the kidney after having done the partial nephrectomy. We also basically standard use it now nowadays in our hospital, where we do the neobladders and the ileal conduits intracorporeally. Once we have excluded the bowel piece, we can look with fluorescence whether everything is still well vascularized. And this is a big extra safety measurement in order not to have any complications. Here you see an example of a partial nephrectomy where we want to do a selective clamping. And here you see that we bring in these Scanlon bulldogs. We will do a selective clamping, and we have a look whether the tumor and the area around it is sufficiently vascularized. And you see avascular. And you see that in this case, you see that we already demarcated the tumor circularly, and you see that a part of this tumor is still too vascular. So we will have to do in this case a total clamping of the major artery instead of a selective clamping if we don't want to have too much bleeding. And this is another example where we did a resection of a big tumor very central on the hilum. We did first the inner rhinorrhaphy, then we did the outer rhinorrhaphy, and then we unclamped. And then I had, so we are finishing after the unclamping the external rhinorrhaphy, but then we will look with fluorescence whether the kidney is sufficiently vascularized. And look, you will see that the upper pole is perfectly vascularized. This is a right kidney here, but the lower pole is avascular and does not fluorescence. So we are now freeing, opening a little bit this rhinography, and you see that we had been strangulating the main artery towards the lower pole. And so we were able, thanks to a fluorescence, to spare half of the kidney in this patient. And this is an example of a intracorporeal ileal conduit after having done a cystectomy. Basically, we are making the Wallace plate, and we are using a monocryl for Ofodid in a running fashion. And once we have done the Wallace plate, then we will isolate the bowel that we want to use for the ileal conduit. And for this, we place two 60 millimeter endo-GIAs through the bowel and its proximal mesenterium, if I can call it like this. There we put the second one, and we will see that with fluorescence whether this bowel piece is still sufficiently vascularized. So when we have a look now, you see that this part of the bowel, that the distal part is avascular. So we will recut this part of it so that we won't have any vascular problems once with this excluded bowel. So now we are restoring the bowel transit using the Barcelona technique with endo-GIAs. And then afterwards we will be able to look again with fluorescence about its sufficient vascularization of this bowel piece, and you see that it is completely green and so sufficiently vascularized. But there are also new robots coming, and one of the examples, and this has been tested out by Jan Strasweiler, which you can see here on the picture. So this is actually the Elmet, which is a Turkish company having the Avicenna robot, which is actually a robot which allows us to do remote control of the flexible ureteroscope and to treat stones in the upper urinary system through laser, all with remote control with this new robot. And Intuitive is doing tests with a single port, and basically the single port enables us to bring in through one single port one instrument, so that the different tools will come out like a spider, and so that we can move it all around. And basically here you see a little video clip on how it will work, and it will call the SP system, which is the single port robot. And here you see the instruments coming out of one single trocar, and you will be able to bring them apart like a spider, and this will enable us to do wonderful reconstructive surgery through one single port. This is not available yet, but we hope that this will come available for the ICSI probably by the end of this year or next year. But there are already initiatives looking for even smaller robots. And here you see this mini crab-like robot, which has already been used to remove small stomach cancers. Basically, this is on a gastroscope that they have positioned two instruments which are very small. One is a hook and the other is a grasper, so that basically you can use the hook to cut and to coagulate small vessels, while with the grasper you can pick up the tumor, and there have already been done some treatments with it. So you see that not only the robot is getting more and more through one single insert, but is also getting more and more miniaturized. And it goes even further, and this is an example of a little robot, 1 centimeter diameter, 2 centimeters in length and having 2 little arms and a camera. And so they think that you can indwell it through the mouth, you can inject it somewhere, for example in the abdomen, and you are able to move this little robot everywhere into the body, where it could, for example, be used as a drug delivery injector. But also, this is so a very miniaturized system, and they are still doing some more testing on it to hopefully get it available clinically quite soon. And they go even one step further. This is an example of a mini robot who is only 1 millimeter diameter. You can inject it in a vein, and you can even move it against the bloodstream, and basically it is controlled through magnetism, and we hope that this will be available to bring in some medical treatment, very localized anywhere in the body. But this is not for today, but hopefully for the near future. So to conclude, I think that this is only the beginning of what we have seen in robotic surgery. A lot is to be happening and will happen. Don't worry. Robotics is here and is here to stay. So Dr. Satava told us already that the future of surgery is not about blood and guts. It's about bytes and bits. And so robotic surgery has a very fast penetration in our surgical ORs. It takes over, if we want it or not, most indications for surgery. It will not only be available for urology, but also for other specialties. And robotics is here and is here to stay. But a fool with a tool is still a fool. Appropriate training is mandatory. And robotic surgery today is quite unwieldy. The evolution of the robotic platform and its instrument will only continue to evolve. Thank you very much.